Welcome everyone to our last grand rounds of 2023. For today, we have one of my partners and one of our sports medicine physicians, Dr. Nick Hatamiya. And for an introduction, I'll turn it over to Dr. Center.
All right. Good morning, everybody. I want to welcome everyone here this morning. Thanks for being here, both in person and on Zoom. I'd really like to thank everyone for being here in particular because sports concussion is such an interprofessional and multidisciplinary topic. So it's also my pleasure to welcome folks not only from our Department of Orthopaedics, but also the Department of Family Medicine and Internal Medicine and Neurology and Physical Therapy. I think many of you are on Zoom, so thanks for being here. And thanks also to our athletic trainers who are here in the audience. It's my honor to introduce our grand round speaker, Dr. Nick Hatamiya, who's a primary care sports medicine physician. Dr. Hatamiya was an undergrad at Cal Berkeley and a medical student at Western. He then completed his family medicine residency at the Stanford O'Connor program and went on to primary care sports medicine fellowship at UCLA. Go Bruins. Dr. Hatamiya joined us a year ago in sports medicine. He's done an amazing job seeing patients at the Orthopaedic Institute, the Berkeley Outpatient Clinic, the Pediatric Sports Medicine Clinic in Walnut Creek. He's also co-medical director of the Oakland Roots, our professional soccer team in Oakland. And he's also our fellowship director. So you can tell he's been super busy this year. On the national level, Dr. Hatamiya has been an invited speaker for the American Medical Society for Sports Medicine. That's our professional society in primary care sports medicine. And most recently, he's been leading the AMSSM's faculty development curriculum, as well as hands-on physical exam teaching for our medical student and resident members. I'm excited about this topic. The world of sports concussion has been rapidly changing this year, and so it's great to have an update. There's a lot we can learn. I think that you'll find this topic really clinically interesting and thought-provoking. So please join me in welcoming Dr. Hatamiya.
Thanks so much, Dr. Center. Good morning, everyone. Thanks to those of you in person who braved the stormy weather to be here. Really appreciate it. And I'm honored to be the last grand round speaker of this year. Hopefully you find this topic really interesting. And for those of you on Zoom who may be traveling, please travel safely. As Dr. Center mentioned, I'm going to be talking about sports-related concussions. And I think there's been a lot that's changed in the past several years. And so I really wanted to give some key updates to this group. I have no relevant disclosures. And I want to start by recognizing that many of you may not see sports-related concussions clinically, but I'm sure that some of you may have experienced a sports-related concussion yourself, or know a family member or friend who experienced one, or may see patients in clinic that had a traumatic injury that also sustained a concussion. And if you don't fit into any of those boxes, then I'm sure you've probably heard of at least a sports-related concussion in the media. I feel like there's not a week that goes by where we don't hear about some professional athlete sustaining a concussion. As an example, as I was preparing for this talk, I just looked at how many concussions I saw reported in the media. And this is just over the past week. And these are all different athletes, mostly just in basketball and football, because those are professional sports that are in season. But it really gives you the idea of how many sports-related concussions that we're seeing, and that's prevalent in our media today. If you don't follow the national sports landscape, maybe you're more local sports fans. Here in San Francisco, obviously with our 49ers, Brock Purdy, our quarterback, sustained a sports-related concussion earlier this season. If football is not your jam and baseball is more your thing, then you may remember our young catcher, Patrick Bailey, on the Giants had a concussion. And if you're not a sports fan at all, hopefully you're a fan of our department, and you may see headlines from our very own Dr. Rob Pandya and Brian Feely, the radio, talking about sports-related concussions. And there's a lot to go through with concussions. And really my goal is to give you all a better sense of what these athletes go through when they sustain a concussion, from the diagnosis standpoint through the management process, and how we get them back to returning to play on the field, and if they're in school, back to returning to learn. So I'd like to start today by just giving some brief background about what sports-related concussion is, and give you an overview of the pathophysiology and the epidemiology. We'll talk about some of the new tools that we have to do diagnosis and management for sports-related concussions. We'll talk about updated return to learn and return to play protocols. And then we'll explore the role for exercise in sports-related concussions and how this can help facilitate recovery. And I'll conclude by talking about some opportunities for improved care and access. And this is all really timely because this past summer, a new consensus statement was released by the international experts in sports-related concussions. This is the Concussion in Sports group. They've been meeting since 2004, every 4 years, but got delayed a couple years because of a small thing called COVID. And so prior to this, their last consensus statement was in 2016. So many of us were eagerly awaiting their latest updates. And so a lot of the things I'm going to be talking about come from this consensus update. All right, so we'll dive into defining what a sports-related concussion is. And broadly speaking, we know that it's a traumatic brain injury that's induced by biomechanical forces. And when we look at the updated definition, we know that it's caused by a direct blow to the head, face, neck, or elsewhere on the body that results in an impulsive force that gets transmitted to the brain. And this initiates a complex neurometabolic cascade, which I'll talk about in some of my future slides. We know that the signs and symptoms can present immediately, but may evolve over hours, minutes, and typically they'll resolve within a few days, but in some cases they may be prolonged. And usually no abnormalities seen on our neuroimaging studies. And as you may know, this results in a wide range of clinical signs and symptoms that may or may not involve loss of consciousness. And I think we all recognize now that you don't have to be knocked out, so to speak, to sustain a sports-related concussion or just a concussion in general. And more importantly, the clinical signs and symptoms of a concussion cannot be explained otherwise by other things, so drugs, alcohol, other medication use, or comorbidities, but they can occur concomitantly with this. So now that we know the updated definition, let's talk about how it happens. And I will preface this by saying this is a broad overview and an oversimplification of a very complex topic, but hopefully this gives you a general sense of what we think happens when a sports-related concussion occurs. At the broader level, we know that there's a force to the brain that causes shearing forces at the axon level. And this results in an indiscriminate release of neurotransmitters. And like many of you, I'm a visual learner, so I like looking at graphs and charts. And this graph, I think, really depicts it nicely. So on the x-axis here, you can see time depicted in minutes, hours, and days. And on the y-axis, you see percent normal. And a lot of these lines represent different ions for the most part. And so you can see in that acute phase, there's a huge increase in the percentage of the amount of ions that we see. And at that same time, we have decreased cerebral blood flow. And like anything in the body, we want to maintain homeostasis, but that requires energy. And what happens is we get a high demand for glucose because we need that energy, but we know that you have decreased cerebral blood flow as well, so the blood can't get there. And you're in this hyperglycolytic state that can lead to increase in the acidic concentration and increased permeability of the membrane. And this leads to a mismatch, and that energy crisis is what we suspect causes the symptoms related to a concussion. If we look at the epidemiology, we know that there's around 3 million sports-related concussions that occur annually in the United States. And a large proportion of those are in our younger athletes, so in children or adolescents. And this is using emergency room data and larger surveillance systems, so it's likely an underestimation of the true amount that's occurring. We have seen an increase in sports-related concussions that have been reported over the past several decades, and this is largely attributed to increased awareness and education, both from a provider standpoint as well as a patient standpoint. Some more recent data from the CDC looks at that younger population specifically, and this is based off of the National Health Interview Survey, and they broke it up into 3 different age groups, and you can see that the older age group tended to have more prevalence of concussions compared to that younger age group. And interestingly, when you break this data down based off of sex and race, you see there are a little bit of disparities there. So boys tended to have a higher reported rate compared to girls. And then you also see some racial disparities with non-Hispanic whites having higher rates compared to the other demographic groups listed there. And we'll talk about that towards the end of my talk. I'd like to shift gears and talk about some updated tools for concussion evaluation. And I'd like to present a case to you all that we can kind of think about as we go through this. So let's say you're at your child's soccer game or your friend's child's soccer game. They're the all-star striker and leading scorer. They go for a 50-50 ball and get an elbow to the head from an opposing player. They're a little slow to get up. They say, yeah, I have a little headache. I'm kind of dizzy, feel a little woozy. Otherwise, they are really excited to go back into the game to play because it's the championship game. And if they make it, they get to travel to Hawaii to play in the next game. Everyone's looking at you because they know that you're the healthcare provider. Maybe it's your own child. And, what are your next steps? What are you going to do? What are you going to say? What tools are you going to use to evaluate this person? Or what questions are you going to ask? So part of that consensus statement that came out also came out with a new suite of tools. So I mentioned that the first group met back in 2004, and they created the first sports concussion assessment tool, also known as SCAT. And now it's in its 6th edition. This gives you an idea of all the different tools that they presented in their latest consensus. We won't go through all of them in detail, but we will go through some of them. So on the sideline, the tool that you should use is called the concussion recognition tool. And this is really to be utilized to increase your suspicion as to whether or not a sports-related concussion may have happened. And like with anything, when you're on the field, this is the process that I typically go through. So you want to rule out any red flags, right? First, make sure the scene is safe. Then you want to rule out any cervical spine injury or head bleed. If you do have a concern for that, then we usually activate our emergency action plan. But if you don't have any concerns and you think it's more just a concussion or even something else, then it's safe to do a sideline evaluation. Part of that sideline evaluation looks for some signs and symptoms that may make you suspicious of a concussion. Excuse me. There can be physical signs that may manifest. They may be dizzy, nauseous, and they may tell you this. They may be more emotional. So they may be crying, they may be very angry, and they may not just be making sense, so they can have changes in their thinking as well. One of the core things that have been a part of this tool since the first SCAT are something called the Maddox questions. This was derived from David Maddox, who's an Australian, back in 1995, and it largely deals with questions that relate to the event that you're at. And I heard some chuckles from the audience, but as a Cal Bear myself, even though I did my residency at Stanford, I always take pleasure in showing scores of Cal beating Stanford. And we did win the big game this year, so go Bears. But, I leave that there because if you don't know the answer to some of these questions, you can always reference the scoreboard as well. And these questions are, where are we today? What event were you doing? Who scored in the last game? What team did you play last week? And did your team win the last game? And we know that if they answered these questions incorrectly, that it has a really high specificity for sports-related concussion, and there's a really low false negative rate. And I think if there's any question as to whether or not someone has a concussion, it's important to sit them out. Dr. Sandra loves saying this, so she always says, when in doubt, sit them out. And that holds true in our research because we know that removal from play can impact concussion recovery. This was a retrospective cohort study that's part of the CARE Consortium, which is an alliance between the Department of Defense and the NCAA, and included 30 universities and 4 military academies. And what they looked at was 2 questions. They asked, did the athlete immediately report the injury? Yes or no? And then was the athlete immediately removed from play? Yes or no? And if they answered yes to both of those questions, they were placed in that immediate removal group. And if they answered no to one of those questions, they were placed in that delayed group. And what they found here was that the immediate removal group had a lower likelihood of missing more than 2 weeks and an even lower likelihood of missing more than 21 days. And when this study was published, 21 days was kind of defined as having a protracted recovery. And that definition has changed a little bit. But the general takeaway from this study was that early removal can lead to quicker recovery. They also looked at the symptom burden and found that those that were removed sooner had a lower symptom burden as well. We also think there might be a dose response related to this. So this was a prospective study that looked at 130 athletes, a younger cohort, 11 to 19. And these athletes self-reported when they felt symptoms, and then how long they played after they felt those symptoms. And there were 3 groups that they put them in. So they put them in the immediately removed group, so those that reported their symptoms and were immediately removed, and then a short play group who played for about 15 minutes or less. And those that went beyond 15 minutes were classified as the long play. And they followed these groups out to see how long it took for them to recover. And so in this graph here, you can see each of those groups listed, and then the amount of days it took for them to be cleared. And there was a significant difference between those that were removed immediately compared to the long play and those that did short play and long play. We also know that when we look at the removed compared to short and long, that the risk for protracted recovery, there was a higher odds of you having a protracted recovery if you stayed in the game longer and weren't immediately removed. And so there may be a possible dose response effect for continuing to play on concussion recovery, but I think more research is needed in this realm. So going back to that soccer player, that child, so we're on the field, we're looking for red flags, we don't really have any, we're suspicious of a concussion. Is there anything else that we can do? And there are some tools that you can use in that acute setting. So the SCAT is the sports concussion assessment tool. Part of the SCAT has a sideline evaluation component that you do, and then the other component has a more comprehensive exam that should be done in a more quiet space So if you watch any NFL football games, you may see them go into that little tent that they can pop up. Or if you are suspicious of a sports-related concussion, you can always evaluate them at halftime or after the game. And this is best used in the first 72 hours. So prior to the release of the consensus, at least here at UCSF clinically, where we're still using components of the SCAT in clinic. But we know that it's best used in that more acute setting. And as a result, they came out with the sports concussion office assessment tool, which we use now more clinically. This is best used beyond 72 hours. And they have different components listed there. That's based off color grading. So they have components that should be used during your first assessment of the patient, and then things that they recommend, and then optional components as well. This is a really long process to go through or evaluation, but I think there's some really helpful things that we'll go through as we talk about my next slides. So some of the optional things that got added as a part of the new consensus are screening questions related to mental health and sleep. And so on the top left here is a depression screen. This is a PHQ-2. And if that's positive, you can move on to a PHQ-9. There's also an anxiety screen, and this is the GAD-7. They added a sleep disorder screen, which asks questions like, how many hours did you sleep last night? They may have a wearable. I'm a wearable junkie. I have 2 on my hands right now. It just tells me that I don't sleep enough. But I think that that's an important question to ask because either they may have an underlying sleep disorder or they may not be sleeping as well when they have their concussion. That can impact their recovery. And then they also look at if they have trouble falling asleep, staying asleep, and if they're using any medications to help with their sleep. And I think it's really great that this got added into the scope because we know that mental health and sleep is a big factor that plays a role just in society in general, but specifically with those athletes sustaining a sports-related concussion. And there's been a lot of systematic reviews and meta-analysis looking at this, both on the impact of underlying mental health and sleep disorders on concussion recovery. And as you can imagine, those that sustain a sports-related concussion have increased feelings of either depression or anxiety because they're not a part of their team, they're not playing, maybe they're worried about their next contract, and that can also impact their sleep as well. I think one of the most useful things as part of that new tool that came out is the symptom evaluation. And this is something that we've been doing for a while. But the reason why I like it is because, as I mentioned in the definition, there's a lot of different signs and symptoms that can present as a sports-related concussion. And so what you will have your patient do is list all the symptoms that they have. So they go through this huge list here and mark yes or no. And if they do have it, then they grade it on a scale of 0 to 6, 6 being the most severe. And they may have done this when they had that acute evaluation, and when they follow up with you, if they bring this in, it's really helpful because you can see more objectively if they're getting better from a symptom burden standpoint. And it also helps you know what symptoms are the predominant symptoms that they're experiencing. And so you'll total the number of individual symptoms that they have, as well as their total symptom severity score, and tally that. And then also ask them if their symptoms get worse with cognitive activities or physical activity. And then ask what % of normal they feel themselves. So on a scale of 0 to 100%, where do you lie? And they may say, I feel about 60%. And, especially for my younger patients, I say, well, what is that extra 40%? Like, what's making you not feel right? And that can really help you dive a little bit deeper into what they're feeling with regards to these symptoms. So beyond that symptom score, we also do a series of cognitive tests. And part of that is testing their immediate memory. And this is done by doing delayed word recall. And so you can all practice this, and I'm going to actually quiz you at the end. But what happens is I'm going to read you a list of words, and then I want you to repeat them back to me in any order. And we'll kind of practice one trial. So I'll say jacket, arrow, pepper, cotton, I need glasses, movie, dollar, honey, mirror, saddle, and anchor. And then I'll have you repeat those back. And so you can just mentally in your head repeat back as many of those words as you can. And we'll do that 3 times, okay? And they expanded the word list with this new tool to a 10-item word list because it previously used to be a 5-word list, and there was a ceiling effect to that. So, me as the provider, I had the whole 5-word list memorized. I could spew off to you elbow, apple, carpet, saddle, bubble, right? And so you can only imagine an athlete who's sustained a concussion and is getting repeat evaluations by their physician, or if they've had a concussion before and it's their 3rd one and you're using the same tool, they may know the word list. I remember when I was a fellow, I was evaluating a water polo player, and I said the first word, and then he spewed out the whole string of words to me. And so this 10-word list has been studied, and there's not that ceiling effect. So I think that can be really helpful. And so try to remember as many words as you can, because what happens is we do a delayed word recall as well. Another component of the cognitive test is doing digits backwards. So you start with a lower string of digits composing of 3 digits and then slowly, gradually increase that. So for example, if I say 719, I'll have you repeat it back. So 917, and we'll go through each of those individually. And then we just have them do their months backwards. And if they're younger and they may not know their months, there's a child scope where you can do the days of the week in reverse order. After I do those cognitive tests, I usually move on to the physical exam. I think nothing beats your physical exam. So cervical exam and neurologic exam, doing a thorough neuro exam, I think is really important. And then a new thing that's recommended is collecting orthostatic vital signs. We know that in some athletes that have concussions, they may have more autonomic type symptoms. So for example, when they change positions, they may get lightheaded, they may feel their heart racing, or they may get really flushed. And so orthostatic vital signs is a recommendation as part of this scope. Some additional exam that we do include the modified BEST, which is the balance error scoring system. And this is a depiction of what it looks like. This is not my doppelganger. I got asked that a question once when I was presenting this. I wish I was that ripped, but unfortunately I'm not. But what you have the athlete do is you have them stand in different stances. And the first stance is going to be with their feet together, and then they'll stand on their non-dominant foot, and then with their non-dominant foot in back of them, so in tandem stance. As they do that, they keep their hands on their hips and they keep their eyes closed. And you monitor them for 20 seconds. And what you're looking for is how many errors they make. And an error is defined as whether they open their eyes, if they lift their hand off their iliac crest, if they put their foot down, or if they kind of shuffle their feet. That's defined as an error. And so you tally all of those up. You can do it on an uneven surface. I rarely do this, but a good use case would be for a gymnast, for example, who you may suspect a concussion that has really great balance, just at baseline. So they can have like the worst concussion in the world, and you have them stand on one foot and they're just rock solid, right? So adding an RX pad underneath can be helpful to make it more unstable. Obviously, you don't want them to fall. And if they're very acutely concussed, I usually will defer this. After that BEST, you can do a tandem gait. So this is observing them walking in a straight line over 3 meters, and you can time them as they do that. And you're just looking to see whether or not they're unstable or sway. And then you do the modified vestibular ocular exam. And the VOMS test assesses the vestibular and ocular system in 5 different ways. So the first thing that we do is we look at smooth pursuits, where you have them track things horizontally as well as vertically. And then you have them do horizontal and vertical saccades. And we can all practice this together as we're sitting here, but you'll put your hands about 3 feet apart, and you're going to keep your head straight. And what I have them do is I have them lift between their fingers as quick as they can. So they go back and forth as quick as possible. And you also do that in a vertical way as well. And what you're looking for as they do these tests is if they develop any symptoms, specifically headache, dizziness, nausea, or fogginess. And if they do have those, you have them graded on a scale of 0 to 10. After they do that, I do near point convergence. And the literature says that you can have, you can use a tongue depressor or whatever you may have, but it has to be 14-point font. And they focus on that 14-point font and slowly bring it closer to their nose. And as they do that, you have them stop once they see double. So once they see 2, whatever you have as 14-point font, you have them stop there, and you measure from the tip of the nose to where that they end up stopping. And anything that's less than 6 centimeters is considered to be normal. Then you move on to the more dynamic test, which includes the horizontal vestibular ocular reflex, or VOR. For that, you have them fixate on that 14-point font, and at a rate of 150 beats per minute, you have them turn their head back and forth. Sorry, it's 180 beats per minute. You have them turn their head back and forth while they fixate on that object. And then the last one is the visual motion sensitivity. And you can practice this as well, but I have them put their thumb out straight in front of them. You fixate on the back of your thumb. So I say, look at the back of your thumbnail, and they rotate side to side, 20 degrees each direction at a rate of 50 beats per minute. And then again, you ask if they develop any of those symptoms. And those are pretty dynamic tests, but it can be really helpful in helping you elucidate whether or not you suspect a concussion. So we know that those who don't have a concussion tend to have very few symptoms with VOMS testing. The VOR and the VMS, so the vestibular ocular reflex and the visual motion sensitivity, seem to be the most predictive out of those tests. If their VOMS total symptom score is greater than or equal to 2, then it can increase their concussion probability by 50%. And then that near point convergence distance, if that's abnormal, then that can increase your concussion probability by close to 40%. And this has been studied. This was a recent systematic review that was published, and has pretty good sensitivity and specificity, and it's best when combined with all those other elements of the scope. So after we've done all those different tests and exams, the last thing I do is I say, well, can you repeat how many words you remember from that 10-word list? And you may be thinking to yourself, oh, I remember some. I think there was jacket, arrow, cotton. So you'll read out as many as you can and you mark down how many they're able to get. There are other optional components that we won't go through, but instead of a 10-word list, there's a 15-word list, which I haven't used yet. Hopefully I won't have to, but that's available. You can also do a complex tandem gait. So they will walk in a straight line going forwards with their eyes open and then close their eyes walking forwards. And similarly, you can do that backwards. There's a dual task gait, which I use frequently. So while they do their gait, you can have them say their months in reverse order or do serial sevens. There's also computerized testing, which we do in our clinics, but not all clinics have, and then a graded aerobic exercise test that I'll talk about in some of my future slides. So based off of your assessment, concussion diagnosis is really still a clinical diagnosis. And even though we have all these tools, there's no gold standard. And so it's really up to your own clinical intuition and history as to whether or not you're suspicious of a concussion. We'll shift gears and talk about how we return these athletes to learning and playing. And I think that begs the question, well, what is recovery? How do we define when someone's recovered? And there's really two key components. It's returning to learn and then returning to sport. And for student athletes, I say first you have to return to learn, and then you can return to sport because school is the most important thing for our student athletes. In reality, these kind of go in tandem with each other. And the definitions of those, so returning to learn is going back to their normal pre-injury learning activities without any academic accommodations. And then return to sport is completing a return to sport strategy. And they can't have any symptoms as they go through that return to sport strategy before they're cleared at the very last stage. And we'll talk about that too. So for the graduated return to learn, this is a stage protocol. And I know this is a very busy slide, but we'll go through it individually. So in the beginning, when they're acutely concussed, they may not want to do a whole lot, but it's really important for them to try to start doing some of their daily activities. So they're at home and it's really just focused on first, nutrition, sleep, hydration, and then making sure that they're able to start doing things for themselves while they're at home. And they can gradually increase that and start doing more of their typical daily activities. Once they tolerate that, then they can start trying to do some schoolwork at home. And as they do this, it's okay if they still have some symptoms while they do it. We just don't want their symptoms to get more severe as they go through this process. But if there's asymptomatic or, doing well when they can do their daily activities, then we can start having them catch up on schoolwork at home and slowly increase that cognitive load. Once they're able to do that, then we say, okay, you can go back to school part-time. So they may be going for half days or partial days while trying to increase their academic activities and load. And they can slowly wean themselves up or ramp themselves up to going to full days. And once they're close to that, they can go to school full-time. And the goal is to really get them caught up on their projects and schoolwork. And I think it's really important for our student athletes to give them academic accommodations. One of my mentors loved to say that we have to break the lazy athlete stereotype. And I think that's really important. And there's a lot of things that we can do to help these athletes go back to school. This form, you can't see it, I know, but is on the California Interscholastic Federation website. And I like it just because it has a bunch of the different accommodations there. You can just check off boxes as to what you want them to have. But, accommodations can be attendance to school, breaks, which we talked about. Let's say they have more visual symptoms where they're having a hard time tracking things, or if they're really light sensitive, then you can have them get accommodations for that auditory or visual stimulus. So, all of the students these days are staring at screens, so they can be old school and print out things, right, or print out a PowerPoint, which might be helpful to reduce that screen glare. Or if they're able to have lectures recorded, they can listen to it, right? So they don't have to read as much. And then, prolonging tests, having extra time for tests or delaying projects, I think can also be really helpful. And obviously, notes for PE and staying out of physical activity. This is a new systematic review and meta-analysis that was published that looked at how long it took for athletes to return to school in sport. And it was close to 300 studies that they looked at. And they found that the mean return to learn was about 8.3 days. And there were similar recovery patterns in all cohorts. And return to sport tended to take a little bit longer than that return to learn protocol. And altogether, they found that 93% have full return to learn by 10 days. So I think, if someone's asking you to have a standard concussion, you can say, well, on average, it takes around 10 days for most people with concussions to kind of get back to learning. We're also looking at whether the level of school matters. So this was a retrospective single institution study that looked at different groups, so middle school, high school, and college. This was out of Vanderbilt. And they looked at how many days it took for them to return back to their academic activity. And they found that the college athletes, interestingly, had a little bit longer return compared to those cohorts. And then for the high school group, the younger athletes tended to have a longer recovery time. So the freshmen and sophomores compared to the juniors and seniors, which is interesting. But, I think this just shows that varying academic environments may impact return to learn. And obviously, there's a lot of factors that may play into this as well. So now that we know how to return them to learning, let's talk about how to return them to sport. And I think one of the biggest updates from that new consensus is that it's really important to promote early symptom-limited physical activity. So with the return to sport, this is a stage protocol where they progressively return back to their physical activity, and they have to spend 1 day at each of these stages. And it's okay, as I alluded, for them to have mild, brief exacerbation of their symptoms. And this is defined as being no more than 2 on a 10-point scale that lasts for less than an hour compared to their baseline. In California, I'll mention that it's law here. There's Assembly Bill 2127 that was put forth that says any athlete who's less than 18 years cannot return any sooner than 7 days after being diagnosed with a concussion by a physician. And they have to complete a return to play protocol. And then a certified athletic trainer or concussion monitor has to sign off on each of these stages as they go through that. And equally as important, all coaches are required to receive training on concussions, which I think is great. So this return to sport protocol, another busy table, but we'll break it down. So in the beginning, they can do symptom-limited activity, and this includes reintroductions of normal daily activities of living that don't exacerbate their symptoms. Usually that's around the first day or so. And after that, I really try to get them to be more active. And the second stage is light aerobic exercise. And you can further break this stage down into 2 different categories. 2A, where they do light aerobic exercise around 55% of the heart rate max, and then moderate, which is about 70% of their heart rate max. And for this is a controlled activity that increases their heart rate. I like to do stationary biking because it's very controlled and they don't get lots of visual stimulus coming in. If they're on a treadmill or walking, sometimes they get head bobbing or that visual stimulus can be a bit much for them, but either or is fine. And as they progress through this, you're really just looking for worsening symptoms that go beyond that 2-point scale that lasts for a longer period of time, or more symptoms, right? So if they go out and walk and they have a mild headache, and that goes from a 2 out of 10 to an 8 out of 10, obviously that they did too much. Or if they start getting dizzy, nauseous, or they don't feel well, then they did too much as well. And you can have delayed symptoms too. And so I would say your brain has a certain amount of fuel it can use, and you can either use it like cognitively or with aerobic exercise, and just try to test one thing to see if you get symptomatic, just to be very controlled about it. And once they're able to kind of tolerate that light aerobic activity, then we allow them to do sport-specific activity. And this is still training away from their team environment, but includes things like running, change of direction, individual training drills. And you just really want to make sure there's nothing that will put them at risk for having a head impact. This line here represents the time at which they need to be symptom-free, though, before moving to the next step. So this is new in our guidelines as well. But after that sport-specific exercise, they have to be symptom-free before they can start doing those non-contact sport-specific drills. So this is when they can integrate back into their team, but they're still doing non-contact drills. So they can do passing, multiplayer training, and be like a neutral in soccer where everyone just passes to them and they're always on offense, but they don't fight for 50-50 balls. And they're exercising at a higher level of intensity. If they continue to do well with that, then we allow them to go back to full contact practice. And I think the really important thing for this stage is to assess their psychological readiness, because it may have been several weeks as they've been going through this process, or if they've had repeat head impacts, for example, they may be hesitant to return back to doing full contact activity and going back to sport. And so I always just ask them how they feel about that. For my younger ones, most of the time they're very eager and you just got to pull them back. But, I think it's a really important thing just to ask. And if they do that fine, then they're able to finally return back to their sport. So I think the most common question, hands down, that I get, no matter what stage of this concussion protocol that we're in, or even if it's during the diagnosis stage, is when can I play in the game, right? Like even that scenario I gave you with that child is like, I want to go back and play. And I say you have to do 2 things. You have to complete that return to play protocol, and you have to be back in school without any symptoms, and then you can go back for sports. And it's really important to be cleared by a physician before they're able to do that. All right. So now that we know both the return to learn and return to sport protocol, I want to talk about the role of exercise for concussion recovery. I'll present another case to you all. Let's say that there's a 21-year-old collegiate female water polo player. She suffered her third concussion about 6 weeks ago. Her 2 prior ones were uncomplicated, and she recovered quickly within a couple days to a couple weeks. She has a persistent headache, though, and some mental fogginess and difficulty concentrating. She's tolerating some of her schoolwork, but still needs breaks. And then her biggest thing is she really hasn't been able to progress to activity. So she's been trying to go through that return to play protocol, but every time she progresses to the next stage, she gets a lot of symptoms and she feels like she's just stuck there. Her exam otherwise is normal. She has no vestibular ocular symptoms. And so in this case, this isn't uncommon. It's something that we see quite often, but this patient's suffering from what we call persistent post-concussive symptoms, or they're having prolonged symptoms. And this is now defined as greater than 4 weeks in all groups, so children, adolescents, and adults. It used to be thought that the children perhaps had a longer concussion recovery time compared to adults, but with our latest consensus, at least for sports-related concussions, we've classified them all together. And for these patients, really, you need a multidisciplinary concussion clinic or a multidisciplinary approach to tackle this. And so, we have a lot of other health professionals that we have the privilege of working with here at UCSF, which includes, PT, optometry, ophthalmology, neuropsychology, neurology, obviously my primary care sports medicine colleagues, and psychiatry or other mental health professionals. And at our concussion program, we have excellent leadership from doctors Hatamiya, Center, and Watkins, and a multidisciplinary team of primary care sports medicine providers ranging from PM&R, pediatrics, family medicine, internal medicine, and then led by our fearless athletic trainers as well, who help coordinate our clinics. And what we do is we really try to evaluate for a concussion subtype. And this is an emerging concept where you can target your treatment plan based off what domain seems to be their highest symptom burden. And this is more applicable to those who have more persistent symptoms, but obviously you can use this in a more acute setting as well. And this study that was published a couple of years ago, I think broke it down into a couple of buckets that I like to think of when I'm in clinic. So in one group here, you may have the cervicogenic type bucket that have neck pain, perhaps they have headaches. They may have, migraine type headaches or other things, and they may have some exercise intolerance. Another bucket that I see commonly is the vestibular ocular group. And this is the group that has difficulty with their vision, either tracking things or feeling dizzy as they're reading, and also have some exercise intolerance. Another bucket is that mood bucket. And this is those that have more emotional ability, may have anxiety, depression, and they also have some exercise intolerance. And then there's a separate group that has more autonomic or physiologic symptoms, and often this is more non-specific, but this can be like heart fluttering, feeling dizzy when they change positions, and they may have positive orthostatics as well as some exercise intolerance. And so how I approach each of these subtypes, for that cervicogenic group, I really like to prescribe physical therapy, especially if they have tight muscle spasms to help alleviate some of that pain they may be having. And if they have a headache, then we try to treat it with our standard headache care, and it may be more migrainous. And if they have prolonged symptoms, you can talk about more prophylactic type medications that they can use. And in this group, I like to prescribe submaximal exercise. For that vestibular ocular group, I usually will have them start vestibular therapy. Our physical therapists here at UCSF are really great at doing some vestibular therapy with them, focusing on vision things. If they have more symptoms that need care beyond the physical therapist, then I'll often refer them to our optometry ophthalmology colleagues at Berkeley to have a really great sports concussion vision clinic. And then for this group, I will also prescribe exercise. For that mood group, as you may know, with some of your own patients, this can be really challenging to tackle, but I really rely on our psychiatrists and therapists for this. And there are some specialists who focus on mental health for concussion specifically. And I'll also prescribe exercise. And then for that autonomic or physiologic group, I will usually just prescribe exercise. And you may see that the common theme between all these buckets is submaximal aerobic exercise. And we know now that exercise can be helpful for concussion recovery. Obviously, it has many beneficial effects for our health, but we know that it can also impact the autonomic nervous system and help with that cerebral blood flow regulation. If you remember from that pathophysiology, the cerebral blood flow gets decreased. And there's been studies where it can help with cortical connectivity and activation, as well as improve spatial memory. And this was initially done in earlier studies looking at mice, and they found that those that did voluntary exercise had increased cognitive performance improvement on certain tasks with association of upregulation of this thing called BDNF, which is brain-derived neurotrophic factor. We also know from several studies that have been done here as part of the TRACK TBI team from our neurotrauma colleagues that BDNF, when they look at those that have traumatic brain injuries, tend to be lower in those that have prolonged TBI type symptoms. And we know that it's released when we do exercise. So BDNF is something that's released. And we try to leverage this by prescribing exercise. And one way we do this is the Buffalo Concussion Treadmill Test. And this is from John Leddy, who's based out of Buffalo. It's a validated test to measure the amount of aerobic exercise that's safe to perform even in the acute phase of a concussion. And the goal is to really identify at what heart rate their symptoms get exacerbated, and that we'll use that to help design an exercise prescription for them. And this is something that our physical therapists will do. And so how this looks is we have them on a treadmill or even on a bike, and you gradually increase that exercise intensity over time. And as they do that, you take serial measurements of their heart rate, blood pressure, their rating of perceived exertions, and you ask them for any development of symptoms. They get 1 point for every worsening symptom, and then 1 point for each additional symptom that they develop while they do this. And you stop the test when they get 3 or more symptoms, and you record what heart rate that occurs at. And so how we use this data is we identify what heart rate that symptom threshold occurs at, and then we'll start having them do aerobic activities at about 80% of that symptom threshold for 15 to 20 minutes per day. And we repeat this process if they're tolerating it and increase their target heart rate by 5 to 10 beats per minute each time. And once they're able to achieve around 85 to 90% of their max heart rate without symptom exacerbation, then we allow them to kind of progress through that return to play protocol. So it really takes that big stage protocol and makes it more granular at a level where they just try to make incremental changes slowly over time. And you can have them repeat this test too if they kind of stall out and get more symptomatic. And we know that this is helpful for exercise recovery. This was a study published in JAMA Pediatrics in 2019, which was a multi-spectator randomized controlled trial. It looked at 2 different groups. It looked at an aerobic exercise group that did submaximal aerobic activity, which is depicted here in this blue. And then they also had a placebo-ish stretching group that just did stretching exercises alone. And what they found was that the aerobic exercise group on average took about 13 days, or a median 13 days. And then the stretching group had a median recovery of 17 days, which was significant. And so the exercise group had quicker recovery compared to the stretching group. Recent systematic review and meta-analysis looked at the role of early exercise compared to rest, and found that strict rest until symptom resolution is not effective for sports-related concussion recovery. And this is contrary to what we used to say, right? 20 years ago, we said, go crawl in a dark cocoon and don't emerge until you're not having symptoms, which isn't the best thing now. Light intensity physical activity can facilitate recovery, and that sub-symptom aerobic exercise can be started safely. So it's safe to do 2 to 14 days after a sports-related concussion. And then this can facilitate recovery by around 4.5 days. And you can consider an individualized heart rate-based activity to reduce the risk of symptoms lasting beyond that 4-week mark. All right, so to close, I'd like to talk about some opportunities for improved care and access. So, I showed that slide earlier that showed some of the disparities that we see in the data. And we know that there's some studies that look at this specifically. And African-American children were less likely than non-Hispanic white children to present to the emergency room for a concussion. And in this study, they found that even those that presented to the emergency room with a head injury were even less likely to be diagnosed compared to their counterparts. We know that insurance plays a role too. So publicly insured patients are around 40% less likely to follow up for their concussion compared to privately insured patients. And concussed children are more likely to receive academic support if they have commercial insurance or their primary language is English. We know that athletic trainers can be really helpful to help reduce this health disparity. So this study looked at knowledge of concussion symptoms and found that non-Hispanic white athletes tended to have more knowledge about concussions and symptoms related to concussions compared to African-American athletes, except for those who had access to an athletic trainer. And then schools that have athletic trainers had a greater number of athletes diagnosed with a concussion compared to schools without one. So I think having a healthcare professional who's knowledgeable and knows sports-related concussions can help increase our diagnosis and catch these earlier. And we know that concussion clinics can also be helpful to reduce this disparity. So this study looked at a concussion referral network and seeing whether or not there were any disparities in care based off of race, insurance level, language, and found that there were no significant differences. And they further said that having a sports-related concussion center that's assimilated into the community with a school system can be helpful to improve access and reduce those disparities. As you may know, in our department, we're fortunate enough to have the UCSF PlaySafe program spearheaded by Drs. Anthony Luke and Dr. Selena de Borja, as well as Gina Bibiano. And I would be remiss if I did not acknowledge all of our wonderful athletic trainers here who not only help us clinically, but also are out in the community keeping our athletes safe. And our PlaySafe program is pretty widespread. So we take care of a lot of local high schools here in the San Francisco Unified School District, as well as the Greater Bay Area, both in the North Bay and down on the peninsula. We know that not all areas are as lucky as we are here in San Francisco to have athletic trainers. This was a study that was published in 2019 that looked at the census data from the California Interscholastic Federation and found that more than half of our high schools in California didn't employ athletic trainers. And nearly 30% of student athletes in California didn't have access to an athletic trainer. And this is pretty significant because California has the second most high school athletes, second to Texas. But 30% of that population is around 250,000 student athletes that don't have access to an athletic trainer. Our current primary care sports medicine fellow, Dr. Francis Tao, is actually looking at this and relating this to something that's called the Social Vulnerability Index that's presented by the CDC. And our preliminary data has shown that in our recent census from this past year, that still more than half of California high schools don't employ athletic trainers. There's a significant portion that aren't certified. And we found that the SVI score can be related to that access to athletic trainers. So increased SVI score, so higher vulnerability, lower odds of having access to a high school-based athletic trainer. And specific household characteristics, such as being in a single-parent household, poor English language proficiency, or having a household that has individuals with disabilities also decreases your odds. And this is gaining national news. So we know that California's lack of athletic trainers is really impactful and important on youth sports safety for concussions, but just for health in general. And I alluded to the fact that some aren't certified, and California is the only state in the whole United States where athletic trainers don't have licensure. And we're working on this, and there's assembly bills that have been proposed, the most recent ones by Dr. Akila Weber, who's based out of San Diego, to help start a registration process for athletic trainers, which will hopefully pave the way towards certification and licensure. And this is a big passion project of mine, promoting youth sports safety, not just for sports concussions and athletic trainers, but heat illness and everything else that may be related to it. This is a meeting earlier this year in LA that the Team Up for Youth Sports Safety program through the Corey Stringer Institute at UConn, where key stakeholders in California met to discuss this topic. The KSI group comes out with a report card for each of the states on their youth sports safety protocols, and California has a long ways to go. We are tied for last out of all 50 states. And I think a large part of that has to do with the athletic trainer regulation, but hopefully we can only go up from here. Another area that we see some disparities with concussions is with our adaptive athletes. We had an excellent grand rounds talk a couple weeks ago for Dr. Okamami, who talked about the importance of adaptive sports. I had the privilege of covering the International Surf Association World Parasurf Championships a couple of weeks ago, actually it was a couple of months ago, which was a really inspiring event. But we had a situation where an adaptive athlete needed to be evaluated for a sports-related concussion. As you can imagine, if you think about all those things that I listed that we use to evaluate athletes for sports-related concussion, if you have an adaptive athlete, you may have a spinal cord injury, may have low vision, or use a prosthesis, you can imagine how challenging it might be to kind of go through that. And we are making progress in this realm. So this was the first position statement that was published by our sports medicine colleagues back in 2021. And what I like about this position statement, and this is a busy slide, but they basically break it down based off of different adaptive athletes and what considerations you need to take as you go through that concussion evaluation and return to play protocol. So as an example, if you have an athlete that's a spinal cord injury and impaired muscle power, it lists whether you need to variate anything in your evaluation of them, and then considerations as you progress them through that return to learn. So modifiable things or other things to think about as you go through that process. In this population, it's really helpful to actually have a baseline. So if you know the athlete, it's good to collect a baseline for them, because when they do get a concussion or you're suspicious of one, you know what that baseline is. So when you evaluate them, you have something to compare to. And I think the biggest thing is that more research is urgently needed in this area to develop a better understanding of the intricacies and that are related to this group. So in summary, I know there's a lot to go through, but we talked about some of the background of sports-related concussions. We went through the updated tools that we use for concussion diagnosis and management, talked about that return to learn and return to play protocol and how it's okay to have mild exacerbation of symptoms and start early subsymptom aerobic exercise. And we talked about how exercise can be helpful for concussion recovery. And then finally talked about some opportunities for improved care and access related to concussions. Here are my references. Thanks so much. Happy holidays from the Primary Care Sports Medicine team, and go Open Roots. Happy to answer any questions. Thank you.
All right. Thanks, Dr. Hatamiya. That was a lot of great information and excellent talk. I see a hand up from Dr. Lotz, so we'll start there. And if anybody's on Zoom with questions, put your hand up on Zoom.
Thank you. That was a great presentation. I have a question about how sophisticated we are in terms of quantifying the effectiveness of countermeasures, whether it's training, helmets, and do we know what the exposure is we're trying to reduce? Is it peak acceleration, rotational, area under the curve, multiple over time? Is it kind of guess and check right now in terms of what you do to prevent these injuries or reduce them?
Yeah, good question. I think, that's equally as important as all this stuff I talked about is prevention. And there's been a lot of stuff that has looked at prevention strategies. And this is our most recent systematic review and meta-analysis that looks at those that have been ineffective for prevention. So we know that rules and policy change can be helpful for that. Mouth guards in ice hockey has been shown to maybe be helpful, but not in other sports. With football, I think you're relating to, they have lots of those head telemetry impact sensors. And the data just isn't there yet to know either how many impacts you need, what type of rotational forces. Is there a burden over time? It's really hard to study, and nothing's really panned out yet in the literature, but hopefully we'll try to find something. But we know that just limiting contact practice can be helpful as well to reduce that.
I'm sorry, can I have one more question? Got
Yeah.
the microphone. I'm wondering about the ability to detect a concussion. Does that benefit from having baseline assessments on all these athletes? So it's a delta for the individual as opposed to just look, because that memory test, for example, may be very...
Yeah, you're right. So studies have also looked at that too. And I think in our more elite athletes, it can be helpful. So like for the Oakland Roots, for example, we collect baseline data. For a lot of our Division I colleges, we'll collect baseline data. And there's been some studies that show that that can be helpful. But in our younger population, we don't have the luxury of doing that.
Thank you. That was really, really excellent and really timely. I don't know if anyone listens to the podcast, The Daily, but just yesterday, their podcast was on CTE and younger football players. I don't know if anyone listened to it, but I was really struck. And then your talk is excellent. So it brought up a lot of questions. So is there any way to assess maybe college athletes on, do they have permanent results or early CTE from past concussions? Are there any treatment options for those individuals before they develop lifelong problems? So that was one question. It might be beyond the scope. And my second question is, it kind of makes me think about concussions in the elderly, so you can imagine if you have a concussion in a young person, there's, the problem of long-term effects, but also kids seem to be more resilient than adults. But my dad is 80 and he's still playing competitive basketball. So what happens if he gets a concussion? Like, I imagine he's not quite as resilient. Is there any data in that population? I know I just threw a lot at you.
No, that's fine. Yeah, that's fine. No, totally fine. There are some risks for continued exposure with head impacts. So we know that if you have repeat concussions, it can increase your symptom burden and prolong recovery, right? So it's for those who have multiple concussions, that can happen. It can also increase your risk of having a repeat concussion. And we know that it can increase your risk for musculoskeletal injury as well. A question that also gets asked is second impact syndrome. And this is controversial and rare, but thought to occur when an already symptomatic player returns back to playing. So that vulnerable window that I showed, looking at that pathophysiology, if they sustain a repeat head impact during that time, it can lead to further disturbance in those ions and can be potentially fatal. But I think that's controversial. Long-term risks, we talk about mental health. And so there's a possible risk for mental health problems, specifically with depression. And this is looking at NFL and collegiate football players, but more longitudinal data is needed. And then with CTE, I think that's a hot topic. I listened to the podcast yesterday. And this is hard because it's a pathological diagnosis, right? That's made post-mortem. And you look for that tau deposition. And often they have those behavioral or cognitive effects. And we don't know if there's a cause and effect relationship. And it's really hard to study because it's a post-mortem diagnosis. I think there's definitely a lot more research coming out of there. The Boston group, which was highlighted in that New York Times podcast, is doing a lot of great research out there, but we need more prospective longitudinal studies. And so from a clinical standpoint, I think it's really hard to know whether an athlete has CTE or not. We just don't have that as a diagnosis because it's a pathologic diagnosis. Yeah.
Hey, Stephen, let me back here. Listen, great talk. I'm super impressed by the fact you got a slide for every question before the guys even finished asking the question. So I'm taking notes personally. It's like, that's a really good idea. Listen, the thing I didn't see much about is any medical intervention. By that, I mean drugs or other, we tend to give medications for things, and you haven't given a single medication of physical therapy. So what comes to mind, of course, is steroids. Is there any role for steroids in immediate post-acute head injury period?
Yeah, I haven't really seen steroids, at least for sports-related concussions, be used. The only instance I've seen it is when it's prescribed by neurologists to abort really refractive headaches. That's been a handful of patients that I've seen. Medication use, at least for me, is more along the lines of symptom control, whether that's some of their nausea or headache related. But for sports-related concussions themselves, we don't typically prescribe anything. Yeah.
Dr. Luke?
Thanks, Nick. Great talk, and thanks for all your great work on promoting athlete safety and certification of the athletic trainers. One of the challenges I find taking care of concussion athletes is when they get into that post-concussion phase, and when does those acute concussion things happen and you're getting into other types of symptoms. I'm wondering if there's you showed a lot of pathophysiology stuff. Is it that those neurons are no longer working, or do we have any understanding of why people get those longer prolonged symptoms?
Yeah, I'm not sure from a pathophysiologic standpoint. There's a lot of research actually being done here at UCSF through that track TBI group looking at biomarkers for concussion recovery. And I think that can perhaps allude into some of those things that you were mentioning. And they have found some correlation with it. I have more slides I won't show them, but there's a huge list of different biomarkers that you can look at. And so I think more is to come in that area. And I think that's a really exciting area to kind of think about and monitor, look for those who may have prolonged symptoms, right? And if there's a biomarker that we can look at, or maybe record that earlier to see if they have a concussion or not, or whether this person is going to have a longer concussion recovery trajectory based off of certain biomarkers. So I think in the future, we'll see that.
Hey, thank you so much for the talk. I had a question about the sort of the lazy athlete stereotype that you were talking about. Do you find ever that students are like, oh, this headache, I can't go back to school? Or do you find that they're so motivated to get back to their sport that they're like, I'm feeling good, I want to get back out of the playing field? And what's the balance of that where some kids are like, I don't really want to go back to school, but they want to play in the game? What have you found clinically with that?
Yeah, I would say it's the latter. They always want to go back, right? They always want to go back. And I tell them that they can't go back to playing sports until they're back in school. And so, I mean, that's the bottom line, right? And I think once they hear that, it's like, okay, well, but, there are those athletes that will just circle 0 on their symptom score, and maybe they're pretty good with their test. And that's where some of those more objective, computerized tests can come into play, where you have more objective measure of kind of their cognitive performance. If you have a baseline, you can compare to where they were at their baseline. And if not, there's standard norms based off their age and, sex that you can compare to. That's a helpful way to kind of get those people who may not be as truthful with you. Yeah.
Hey, Nick, thank you. It's very impressive that I met Nick actually almost 18 years ago at Cal.
Yeah.
He was helping out with the men's basketball team. Actually, look what he's doing right now, giving grand rounds, actually a national recognized expert in this area. So proud of you over there. And I think that, I want to, the group to kind of feel good about, all the work that, the faculty is doing. And there's a lot of research to be done, right? I think a lot of things that we still don't know. And I think that the way we treat concussion, as Anthony mentioned, 20 years ago is so different than it is right now. And I think that there are a lot of things that could be done. I think metabolically that you can understand some of the pathophysiology, but I still don't understand why, you actually decrease blood flow when you actually have an area of injury. So a lot of times body responds to injuries with increased blood flow. How do we reverse that with actually, change outcome? So, but thank you for kind of have some stimulating talk, and what a great way to kind of end the year. Thank you, guys. Yeah.
Thanks, everyone.
Thanks, Dr. Hatamiya. And we will be off for grand rounds. Our next session will be January 10th with Dr. Joey Sheridan. So enjoy the holidays and we'll see you then.